Next, I would like to invite Dr. Sanjay Thakur. He'll be talking about analyzing OCT in glaucoma.
Good afternoon, everyone. Somebody change the slide. Yeah. Good afternoon, everyone. My topic is analyzing OCT in glaucoma, some practical tips. So, the first pearl is there are 4 different manufacturers and 3 different parameters we study for glaucoma, and each machine has its own algorithms and display outputs. So, we cannot compare the data of one machine with another. And first of all, we should check the patient's name and age, because all data is compared with age-matched normative database. We should always check the signal strength, and each machine has its own acceptable levels. For Cirrus, it should be more than 6. For Topcon, it should be more than 45. Because certain conditions like dry eye, cataract, they reduce the signal strength, and the RNFL thickness is also reduced. Sometimes a drop of lubricant not only improves the signal strength but also RNFL thickness. It is also reported that there is a 9% increase in RNFL thickness after cataract surgery. And while interpreting, we are more focused on red and green colors. We should know the other colors also, white and gray. The values above 95% of the range is labeled as white, and the values that are not compared with the normative database are shaded gray. This is important. In our over-enthusiasm for embracing OCT in diagnosis of glaucoma, we have come to a stage where there are terms like red disease and green disease. So we should avoid these pitfalls. So sometimes there is a shadowing of blood vessels which causes lower RNFL thickness. And sometimes we see horizontal displacement of images due to motion artifact. This was seen in older machines, not seen now with faster acquisition of images. Every technology has its limitations, so we should keep this thing in mind while interpreting any OCT. Sometimes floater comes in the field of calculation circle, and when we ask the patient to blink, the floater moves away and the RNFL thickness becomes normal. So all these artifacts can be broadly divided into 3 groups: patient dependent like media opacities or dry eye, or operator dependent like signal strength and scan alignment, and device dependent like normative database. So I'll give a couple of examples of each group. Here is a Cirrus print. Here is a Heidelberg printout showing lot of red areas in the clock hour analysis, and when we see the fundus, it is not due to glaucoma but due to toxoplasmosis. So this is red disease due to patient dependence. Here is a Cirrus output showing lot of red areas in the sector analysis, in the clock hour analysis, in the RNFL deviation map. But if we see the fundus, this is myopia. And in myopia, there is a displacement of the superotemporal and the inferotemporal bundles. So the humps are not in the normal place. Though this leads to the normal thickness is there in the RNFL, but because this is displaced, it shows as red areas in the OCT printout. So we should be careful that this is not glaucoma but myopia. Another printout showing a lot of red areas in the RNFL table, and if we see carefully, the disc has not been centered. Now when the disc is centered properly, then all the red areas disappear and the green areas come over. So this is a centration error by the operator. Another example showing lot of red areas from the sector analysis, and in the RNFL graph also it is dipping in the red area and the TSNIT graph. So, but if we see carefully, the RNFL segmentation has not been placed properly in the box. Now when this is placed properly in the box, all the clock hours turn green. So this is another example of centration error. Over here is another example showing lot of red areas in the sector analysis, and even in the TSNIT graph almost reaching 0, which is not possible because the RNFL thickness cannot drop below 30 to 40 microns because of the presence of glial tissue and blood vessels. But this occurs sometimes due to tilted disc or posterior staphyloma, peripapillary atrophy as seen in myopia. So this is a segmentation error by the device. And we should all remember that the normative database of each machine is very limited in number. For example, the very popular Cirrus machine has a normative database of only 284 healthy individuals, and of wide variety of ethnicity, of which only 1% is Indian. And refractive error also, there is a limited range from -12 to +8 diopters. So due to relatively small normative database, many results may be flagged abnormal statistically in patients who are not represented in the database, thus not representing the real disease. So we should be alert about these facts and not treat this red disease. We should always take a clinical overall view before making any decision. The vice versa is also true. Sometimes a glaucoma patient may be missed because of green color. Over here, both the eyes are glaucomatous, but only one of the eyes, on the left eye it's showing red color, but on the left eye it's showing normal. Right eye is normal and left eye it's showing a lot of red colors of glaucoma significance. So this is, if we see the fundus, there is a myelinated nerve fiber which is actually masking the glaucoma because it has artificially increased the RNFL thickness. That is why it is in the white color. So as I said, white color represents more than 95% of the normative database values. So we should be careful. It could be red, it could be green also. So this is an example of a green disease. And another important point we all should remember while analyzing OCT printouts for glaucoma patient, that as I said before, RNFL thickness cannot go below 40 to 50 microns because of the presence of glial tissue and blood vessels. So in advanced glaucoma, it will be a problem. We cannot see the progression because it cannot dip further. So it is good for early glaucoma, pre-perimetric glaucoma patients, but for advanced glaucoma, we have to rely on automated perimetry. So to summarize, OCT alone should not be used to make the diagnosis. We should always make a clinical workup before we see all the parameters and then make a diagnosis. And abnormality in OCT requires clinical correlation. So it's not man versus machine, but man plus machine.
Thank you so much.
Thank you for your time and patience, and thank you APAO Organizing Committee and Scientific Committee for giving me this opportunity.
Thank you so much, Professor Thakur, for this wonderful